It's a pleasure having you once again to talk to us on abnormal pelvic pathology. Hello?
Okay, should we start now?
Yeah, we start. We go.
Okay, go. Good
Go.
morning, Africa. Good 5 a.m. here in Los Cabos, Mexico. Thank you for inviting me and for hearing what I will share. Anyway, first, a quick announcement. If you happen to know her, she's a Ringenia. She's a creature which is only seen in continental Africa or some parts of Asia. If you happen to see her, let me know. We can perform female pelvis examination with several kinds of devices. We could use convex transabdominal approaches. We can use the lineal transducers of not so high frequency. And we could use the endocavitary probes named the transvaginal approach. We can have a state-of-the-art device or a basic device. We don't have to be the owner or the user of an expensive ultrasound machine in order to do world-class ultrasound. So we start. As we all see patients, not chapters in the book, we will cover several topics patient by patient. That's Dr. Pedro's way. So the hardest thing when you start in ultrasound is to figure out what's up on the screen, down on the screen, and each side. And it takes a while when you are training to figure out how you are looking at things. So I should say, for just as a quick reminder, up on the screen is the things that are closer to the transducer, closer to our hand, the patient's skin, then the pelvic wall, a full bladder, and a uterus. We see here a bicornuate uterus. This is a cut or a view in the long axis of the uterus, and this is same uterus but cut through here just by twisting the transducer, which shows two endometrial cavities, echogenic, very similar, not always is like that, and both ovaries, the right ovary, the left ovary. The right ovary is bigger than usual. 4 centimeters is the upper threshold of normality, and in a pattern which allows us to assume that this patient has polycystic ovarian disease, as well as an anatomy variant. This can be a problem with reproduction or not. I've seen patients who have children with just half a uterus. There's a lot of people with differences on inside. Every one of us is different. And not always we don't always see the endometrial as evident as here. We can find just the echogenic line inside divided in two, which show us the presence of a bicornuate uterus. There's a subtle change here which shows the heart-shaped uterus instead of the pear-shaped uterus. And also, this lady has a polycystic ovarian disease. How we look at that on real time? If we scan from the pubic bone upwards, tilting the transducer more than moving the transducer, we can see that kind of image. That's a transverse view and that's a longitudinal view. This is a lady who has a pregnancy in one side of the uterus and an empty endometrium on the other side of the uterus. Let's see it again. Cervix, a mirror-like image here. You see the notch. An anterior uterine surface notch indicates almost always a bicornuate uterus or some degree of bicornuate uterus. This is easily seen with a full bladder or by pressing on the abdomen enough to see the uterus. This is clearly seen and is the line of the cervical channel. Okay, as I told you, upper part of the screen, the nearer part of the patient's body, which means the skin of the patient, soft tissues, bladder, and the uterine fundus pointing towards the patient's back. This is a retroverted or retroflexed uterus and septate. We can see the endometrium here, like an inverted V shape or a boomerang, which indicates a bicornuate uterus. This is the right side of the patient. This is the left side of the patient. If we are looking at the patient like this, the right side of what we are looking on the real life should be accommodated or oriented to the right side of the screen. That way it makes sense in our brains what we are looking at the screen. This is another case of a different patient with a bicornuate septate uterus with two cavities, right and left. And on the right cavity, this is the long axis, we have an IUD on the right endometrium and an empty left endometrium. As you can assume, the IUD was put in place without knowing what kind of uterus we were or they were dealing with. Meaning the use of the IUD or the effectivity of the IUD is compromised because of the shape of the uterus. Everybody know how the IUD works. Basically, it works by provoking early miscarriages, early abortions. So this probably will not work properly because if there's a pregnancy on the left side, this will not work by getting the conceptus out. We can improve the image by looking with volumetric devices like this one. This is a nicer picture with a volumetric 3D transducer and the IUD. This is also a patient with a septate uterus and a hematometra, meaning a collection on one of the sides of the uterus. The right side is empty with an endometrial line, this length, which is not big, and the left cavity has some amount of fluid inside. And the volumetric render of that, which shows here the echogenic endometrium and the empty, well, on the cavity with the collection inside. This is the right cavity and the left cavity and the septum of this uterus in two of the axes of the volumetric scan. Another degree of anatomy variant is the double uterus. We don't have a divided or septated uterus, but a double uterus. We will see how that looks on real-time scanning. Again, we go from one side to the other side. Either by tilting the transducer like that, or by moving the transducer. Many times, if we have a good window in one spot of the skin of the patient, we don't have to move the transducer, but to tilt the transducer from there and then see things through that window. This is another patient with a septate uterus and a pregnancy. Pregnancy is on the right horn, and the left horn is empty. This is skin, soft tissues, some bladder, and the heart, well, fancy heart-shaped uterus with a occupied right horn with an embryo, a yolk sac, and an empty left horn. We can see follicles, and whenever we receive a patient which is under an IVF protocol examination, we can document the size and number of follicles on each ovary. Referral physicians who do reproductive assistance want to know how the ovaries look like, how many follicles and which size the follicles are, and the endometrial thickness. This is a patient under an IVF protocol with an IUD. They're using ovulation induction protocols. And that's the baseline examination through, now you see, this is a transvaginal transducer. This is the cul-de-sac or the vaginal wall, and we are pressing to the isthmus, the uterine isthmus. The cervix is in this side of the screen, and the uterine fundus is in that side of the screen. In order to see things there, we rotate the transducer more than move the transducer. I have a friend who happens to be one of the leading experts of obstetrical ultrasound, Dr. Philip Genty, and he works on Vanderbilt University on Nashville, Tennessee. And then he used to say, well, if you do transvaginal approach, you cannot be doing things that are not necessary. Because remember, you are dealing with a patient, with a human being, not with a number or file to fill up. And husbands on Nashville can be very, very possessive. Anyway, the IVF protocol needs most of the times a follow-up. Here we see wider follicles. This is the 7th measurement, 12 millimeters or 1.2 centimeters diameter dominant follicle, and all the rest are smaller. And variations of the same tone. Endometrial thickness is a useful measurement for IVF experts. We should measure the endometrium from the outer line of both faces, both sides of the endometrium. We're going to go now to see pelvic masses. Pelvic masses can be pelvic, truly pelvic, low, or abdominopelvic, because the location of the size of the mass. Big masses can go all the way up to the liver. And the affected organs of a pelvic mass can be uterus or adnexa. The mass can be cystic, solid, or complex. Usually cystic masses are annexal and solid masses are uterine. Whenever we see a complex mass and is adnexal, we should think on a neoplasia, cancer, or some kind of complex cyst. As we will see further, what is cystic? Cystic means well-defined, encapsulated, and we can see the boundaries of the mass. Not necessarily fluid filled. Can be dark gray or black, but not necessarily, because teratoma or dermoid cyst is a cyst, but it's complex and not fluid filled. Complex cysts are usually adnexal, either ovarian, which can be a cystic tumor, or a hemorrhagic thing like a lutein corpora or luteinic cyst. Remember that the ovulation is basically the rupture of the ovarian wall, and sometimes it provokes an internal ovarian hemorrhage, which partially solid, it makes itself solid inside, and can even be seen as bright spots of hemosiderin inside the ovary. So sometimes ovarian cystic complex things are functional, like luteinic cysts, or non-functional neoplastic, like cystic tumor. We have to interrogate the patient and make our best of the clinical judgment in order to adventurate to have a diagnostic impression to suggest to the referral physician. Extraovaric complex masses can be endometriosis or ectopic pregnancy or infection, some chronic pelvic disease, inflammatory pelvic disease can be shown as complex cystic masses. Here we see a uterus and a cystic complex mass on one of the ovaries. This is a case of the most common benign mass of the young female, usually, which is a small intraovarian teratoma. As you can see, this is a round-shaped thing, wider and brighter than the rest of the ovary, with some small bright white spots. I've seen this patient soon ago, and she still has a teratoma. These are the slides of the same patient showing uterus in a transverse view on the uterine axis, almost left ovary. Remember what is on the right side of the screen is the left side of the patient, because we are looking at the patient like this. The uterine length on the right ovary with the mass inside. An assumed approach of the mass, which shows basically what we already know. A bit of advice: if you look at the regional interest like this, you are applying all the resources of the device to double than the thing that you want to see area. If you limit the area where the device is working, not by using zoom, not by zooming in, but by playing with the depth of the image in order to see what you want to see plus something else, then you improve the quality of the image by putting to work the resources of the device in a smaller area. It's not like augmenting a bad picture, but is by having a better picture. Of course, depending on the device you use, the patient and the conditions of the case, not always easy to see a teratoma. You just do your checklist. Make sure you see both ovaries. Don't miss an ovary. Don't invent an ovary. Take your time, be patient. If you have to press a little bit in order to displace the abdominal air to the sides, do it gently. And remember, some masses are on high locations and better seen through transpelvic approaches than with endocavitary probes. You have to be real and know how to use best your own resources. Not everybody has a state-of-the-art machine, but you don't need that in order to be of service. This is the same patient with a pelvic mass and a pregnancy. Baby with a heartbeat long axis of the, well, no, this is the opposite side ovary, and this is the affected ovary, which is complex, not that easy to see. The deeper boundaries of the mass are lost here. If I point it to you, you can see it. Otherwise, you probably will not see it. You can miss this and think is intestine or something else. And this has been performed with an old ATL Ultramark 9 machine, a piece of museum. When you report the image or let know the referral physician what you're looking at, try to describe what happened during the procedure. If you have had a hard time trying to figure out what happens, and you're the expert on image, or you are performing the examination because a good reason, you know how to do it, or you're training to know better how to do it. So it's not bad to describe what happened during the examination. So the physician who's going to solve or direct the patient to the solution of the problem knows the difficulties that can be encountered for a second opinion, or even for the surgery if needed. So try to be descriptive on everything, not just the image, but what happened. This was described as a very heterogeneous, complex, mobile, encapsulated mass of the right adnexa. So in the final report, I said, this is most probably a dermoid cyst or benign cystic teratoma. You're not a pathologist, but you know very well how a teratoma looks like. So you don't have to fear to give a diagnostic impression. You're not writing a pathology report, but doing the best you can in order to help somebody else. I don't like being mentally cheap as a health provider for the patient. So, not always easy to see, but here there's a clear acoustic shadowing from the ovary, and this usually means this ovary has inside a piece of bone or cartilage, which transmits the sound faster than the soft tissues of the human body. That's why we see a shadowing from here. This is the opposite side ovary, which is small perfect ovary, and the mass, the uterus behind. One of the things of teratoma is that it's classically described as an anterouterine mass, which means in front of the uterus. We can find teratomas frequently in front of the uterus, between the uterus and the bladder, which here is almost empty. So, visual process. Every human being uses the brain in a different form. If you see a painting, even the Da Vinci's Last Supper, some people notices details, some people not. Some people start analyzing by the outside boundaries of the image, then to the center. Some people get to the center. Some brains prefer the darker shadowing sides. Some brains not. Try to be systematic when you analyze what you are looking at. If you are systematic, think on Da Vinci's Last Supper, and perhaps you have not noticed that the guys on the table are grouped in groups of three. Three apostles here, three here by the side of our Lord Jesus Christ, and another three, and another three. The three closer on the right side are Peter, Judas, and John. Why I know that one is Peter? Because it has a knife on the hand. The side on the guy on the side of Peter is Judas because have the pocket of the money on the hand. And the nice looking guy, well, he's John. We can see and not see. And if we read, investigate, know, and then see, we have a better idea of what's happening. So that's why books and workshops and lectures are very good. Not everything is found in your own patient. That's why we are able to learn from others. Sometimes technology doesn't work. For some things, we have to use lower intensities, lower frequencies, turn off harmonics, and see how it looks. Make your own system and choose the system that works, and do audit yourself, examine your own performance, and whenever you can, ask the surgeon what happened and what wasn't. After that general culture capsule, we'll talk about this patient who has been told that she had a fibroid. What she had is a pelvic mass, which is not uterine, is complex, almost 9 centimeters outside the uterus. The uterus has an IUD inside, a low insertion IUD, by the way. Low insertion IUD is defined by more than 2 centimeters distance between the fundus and the upper tip of the IUD. And the mass. The mass is seen here, anterior to the uterus, between the uterus and the bladder. Common location of teratoma. This is a transvaginal view of the teratoma. The probe, the uterus, endometrium, and the mass. And the scan, slightly moving the transvaginal probe and seeing a complex mass. I'll show you. Right spot, more solid, which shows some shadowing. The better your device is, the lesser the odds of having the shadowing. So the definition of stones by the shadowing is not always good. It depends on the examination and on the device you're using. So this is an ovarian mass complex with a solid part and a mildly solid part, and those are adnexal blood vessels. that happens to be another teratoma. Another one, which is now not in front of the uterus, but behind the uterus, uterine length, endometrial line. We tilt a little bit the transducer, and then we find behind the uterus that thing. Which happens to be on the right ovary. This is a transverse view with a good vesical bladder windowing, which shows the uterus, endometrium smiling at us. Right ovary solid, left ovary with the follicles inside, and same thing on the transvaginal approach, the mass, bright spot shadowing the uterus. Sometimes those masses or any ovary that enlarge can twist. It's like having a fruit on a tree. They bigger, they do this. We have to see the ovarian blood vessels. And if we see vessels which go and come several times, changing color things here, we probably are dealing with a twisted ovarian cyst. This is a teratoma, the shadowing, and this is the ovarian blood vessel package. We can see like the artery going and coming twice. Perhaps this is one or two twists torsion of the ovary, which usually doesn't hurt that much. Well, I've never had a twisted ovary, but I've seen a lot of patients. Smile. This is the same teratoma and all the adnexal vessels. And this is another patient with a more complex mass. You almost see the hair inside. Look at those lines. Usually a bunch of hair. If you perform obstetrical ultrasound, you can see this over the head of the baby. This is a right-sided complex cystic mass with a normal left ovary, uterus. And I can bet this is hair. See that? That is gonna hardly be another thing another than the teratoma. This is a teratoma. So, patient with pelvic pain and abnormal adnexa, if it's on the right side, we sometimes have to rule out appendicitis. Typically, appendicitis is a clinically triad of fever, abdominal, right lower quadrant pain, and vomiting, but not always. If we see the appendix is nice and is clear, this is a normal appendix of an adult with a retroflexed uterus, some free fluid, which can be inflammatory. A thick endometrium, we will talk about thick thick endometrium later, and a normal right ovary, and a left ovary which is causing pain on the right side because it's twisted. Sometimes the ovary twists and goes all the way to the other side. This is a complex left ovary, big ovary, almost 6 centimeters, qualifies as a big ovary. And what we are talking about a while ago about the ovarian vessels, you can see a bunch of things which you know is not varicose veins because in real time you see the pulsations of the ovarian artery twisted, and you can document inside the ovary a low speed blood vessel. 20 centimeters per second is relatively low for an ovarian blood vessel, and a complex ovary. Sometimes we see echoes inside an ovarian cyst. It could still be a teratoma, but it could be a dysgerminoma, which is a malignancy usually seen in very young female patients or even children. We will see later a couple of cases of childhood cysts. If you bounce the transducer here, you will see the things floating freely inside the cyst. Some cystadenomas or cystadenocarcinomas can show that too. So what we were talking about, this is an obstetric ultrasound. This is a female fetus with a cystic mass. It's not the bladder, believe me. This is one of the baby's kidneys, and this is the mass. At the 41st week of pregnancy, 6-7 months later, they bring in the child, and what happens next is I still see the cyst. Nobody has done anything, and that baby has a cyst, which is not a simple ovarian cyst. Not common, but I've seen like 10 to 15 cases of ovarian cysts during intrauterine life. And some of those cysts become or are further diagnosed as malignancies. So we have to be careful and do a follow-up of all those childs with things that don't show up outside. They look normal, but something's wrong inside. This is a similar case with a young girl. This is not the uterus. The uterus is behind the mass, small, right ovary, and a complex and very big mass. If you have a device which you can perform extended reconstructions, can do this. Nice picture. Or just divide the screen in the two images you have here and attach the other one here. That way you present nicer, wider, more informative pictures. Even with complex transducers, you can do that. So this is the uterus, the right ovary, and the complex mass, which is which has a blood vessel of low resistance. Typically, low resistance blood vessels, if not pregnant, is malignancy. Low resistance means the difference between the higher and the lower speed is not that big. This is the size of the mass, which is big. And this is a power Doppler image of the same mass. And she's Leah. Leah was managed on the United States with conservative surgery due to a complex cyst. At age 18, she already had been diagnosed of a germ cells tumor. I must say, not properly managed. They were too conservative and tried to spare the uterus and the opposite side ovary. And this happens to be a pelvic malignancy. First is to be, then how to be or what to be. And here we fail like attending physicians if we offer reproductive life to a girl which passed away 1 or 2 years after that. We have a complex, big thing surrounding the whole uterus, which on the transverse view extended looks like the bladder, and it's not the bladder, with an extension to the right adnexa. And eventually comes back with liver metastasis, some complex masses below the spleen, free fluid, the whole scope of an ovarian malignancy in a 19 years old, nice looking and waste life. Just because we try to concentrate something on the transverse view, that's ovarian cancer, not necessarily in postmenopausal woman. We can see that even in childhood. This is a transvaginal approach on the more basic ATL device I mentioned you, with a big, septated, complex, cystic mass in a older than 40 years old female. This was an ovarian cancer. She fought that cancer for 6 years, I think, and finally she passed away. And this is another complex ovarian mass or adnexal mass. We can see normal appearance ovarian tissue here, a big mass behind the uterus with some blood vessels, right ovary with a bunch of follicles, the uterus, the endometrial line, the boundaries of the uterus and the mass. When we press here, it didn't float freely out of the uterine wall, but it was attached to the uterine wall. It moved in one body, which indicates adherential tissue. That's an ovarian complex or an axial complex mass, which was not separated from the uterus, but not sharing blood vessels with the uterus, which means adherence more than uterine nature. It's not a pediculated thing from the uterus, but a thing that attached to the uterus. This is the mass on the right, normal tissue. The left ovary, normal tissue. The left ovarian artery identified by Doppler. And one more ovarian mass. Left ovary, right abnormal ovary. Sometimes this kind of image can be seen in inflamed tubes, which go like that and look like a cyst, but in fact it's the fallopian tube, which is twisted like a snake and folded like this. This is a nice picture of blood vessel in the septation of an ovarian cyst. Usually this means neoplasia, ovarian cancer of some kind. Color Doppler, nice pictures of the right ovary in the vaginal approach. And everybody has the right to have two diseases, two details, to have a big nose and big mouth, fibroids plus ovarian or annexal mass. Uterus is complex with bumps, and one of the ovaries is not that normal. This is not that low resistance. See, the faster speed is very different than the lower, but it doesn't have a negative component of a normal pelvic blood vessel. This is the left ovarian artery going to the mass, which means the mass belongs to the ovary. A complex left ovary in a patient that also has fibroids. After hysterectomy, we can see some abnormal images sometimes. Sometimes it's a collection after the surgery, an abscess or a cyst, or even a part of the tube which has been left there and became inflamed. This is the bladder and a complex, apparently septated cyst. This is an abnormal image after hysterectomy. You should not see that. This is another difficult diagnosed case of free fluid, right and left ovary, and something, something here surrounding somehow the left ovarian artery. We already saw that the left ovary was normal. So this is not ovary. This can be one of the great mimickers, endometriosis, infection. This apparently is an abnormal, chronically ill tube, the fallopian tube, and can mimic the ovary. This is other patient. She has been told to have an ovarian cyst. She even had a C-section without the surgeon doing anything to the cyst. Sometimes they got into the hospital and the professional who is attending them don't know what else than the pregnancy there's inside. And sometimes we don't take a look at the ovaries. They have 2 or 3 more patients to attend waiting outside. So what we saw was this. What we don't see here is the uterus. We see a round cystic thing. This was high, like at the level of the navel, high for being ovary. But we must rule out uh, ovary versus something else. Here on the static view, we can see the bladder from uterus, iliac blood vessels, and the mass. Let's see the video. Okay, here you have the uterus. Perhaps some ovary, blood vessels. We don't see color here because the angle between the blood moving and the transducer questioning is 90 degrees, and the mass. What we do next? Search for the ovary. We should clearly see the ovary. We go to the uterus, tilt the transducer, patience. Here, see? One ovary, left side. At the beginning of the video, we probably see some right ovary behind the uterus. This is the kind of patient who really needs an endovaginal examination. This is a transverse view, same patient, through the pelvis, through the bladder. This can be the ovary, left ovary, or this, who knows? Okay, what's next is vaginal approach. Uterus. One side ovary. See the follicles? Right side ovary. Those are pelvic vessels, but this is follicles. We improve the image by augmenting the gain, and this is a nice looking multifollicular right ovary. This doesn't look like the thing we saw before, the black ball we saw through the abdomen. So we were right. That was not an ovarian cyst. See? Transverse vaginal approach, right ovary. Uterus, ovary, adnexal structures. You can even see the tube. So the patient had not an ovarian cyst. This is a simple cyst outside the ovary. Usually those are parovarian cysts or paraophorus. Whenever we enter into surgery for any reason, mainly C-sections, if we see that, we puncture and aspirate, because otherwise this will give us diagnostic problems further. Right ovary, highly located abdominopelvic cystic mass, not ovarian cyst. The ovary is normal. Sometimes I see the patient and say, did it hurt? And she says, yes. We can see whenever the uterus is cramping. See this? How the endometrial, see that? The squeezing. I could almost hear your ouch. Squeezing down. And some other times we can see things that are not precisely gynecological. Some other than gynecological nature cysts, like this thing, behind the bladder. When we press, we apparently see a flow between the bladder and the thing. See those colors? And from another angle, we see bladder, a cyst-like structure apparently communicated to the bladder, which we can documentate like that. If you saw the flow at blue thing, see? That's a urinary diverticulum. a bladder diverticular disease. Sometimes it's genetic, sometimes it's due to an injury, partial injury of the bladder after surgery, but that's not an ovarian cyst. That's why it's important to put some color on it and see what happens. Uh, we have to understand how color is generated in order to be able to interpret our findings. Very complex pelvis sometimes is endometriosis. Endometriosis is a great mimicker. It can mimic anything, and it can look like that, just an ugly pelvis with big things by the sides of the uterus or behind the uterus. We tilt the transducer, change a little bit the angle, still ugly, I don't know what's happening kind of thing. In the transverse view, or more closer to the transverse view, we can see that. Some points, bright points outside, a complex pelvic image. If we bounce a bit or squeeze or move or use the transvaginal approach and do this and not and everything moves or doesn't move or everything moves in a block, that means if they got into surgery, they will have a bad time trying to fix that. And color flow usually doesn't show much of vascular activity inside, but on the boundaries, we can squeeze a little bit the thing. That's the usual presentation of what we call a chocolate cyst, an endometrial cyst, an endometrioma. So there's been 1 hour. Ask any famous artist. I will give us 5 minutes little break and then we continue with more of this thing. How about that? 5 minutes, jump, smile, go to the bathroom.
All right. Okay. So we'll pause for 5-minute break. All right.
Presentation, share. Oh, my coffee mug, very important.
Yeah, we move.
Once we stretch a little bit, endometriosis.
Okay.
Whenever you don't know what's going on, you have to consider endometriosis, pelvic inflammatory disease, ectopic pregnancy. Whenever you don't really know what's going on, it can be one of the 3 mimickers. Here, we see mass that we can squeeze a bit. Blood vessels surround the mass, not much of inside the mass. Sometimes it's attached to the ovary. We cannot differentiate between the ovary and the mass. And in patients with other indications, we can spot some pathologies like this submucous fibroid, endometrial lining on the ball, which is inside the endometrial cavity, the transverse view, and again, images of reproductive assistance patients. Now under stimulation with follicular growing and post-ovulatory. Remember that I told you about luteum cyst, hemorrhagic cyst. This is how the blood inside the ovary looks like. Heterogeneous echoes inside and sometimes bright spots. Some free fluid, which means the ovary rupture and let go the oocyte. Different case. Patient with continuous having more than usual pain and more than usual bleeding sometimes after a C-section. This is a long axis of the uterus of a recently C-section woman. The uterus length is close to 14 centimeters and it has a collection inside. Sometimes the cervix is closed from the beginning because those are programmed C-sections without labor, and then the blood finds hard to go through the cervical channel. I have a compadre, you know, who whenever he performs a C-section, he dilates with a forceps here, opens the cervix. Some people dislike that because it can contaminate here. But anyway, there's always a chance of hematometra after delivery, especially if it was a C-section. And this is how it looks like. This is the repair of the C-section in the uterus. This is the stitches area. You can see that. And this is the collection inside the uterus. Hematometra or presence of fluid, namely blood inside the uterus, is seen also after a miscarriage. Sometimes the cervix closes tight and then prevents the blood from getting outside. And we can see a collection which is causing cramping. Sometimes can become infected, and that is easily relieved by mild dilation on the office of the cervical orifice. A similar case now on a retroflexed uterus. Sometimes the angle between the cervix and the body of the uterus prevents the blood from getting out, and a clot can be stuck there, and then the uterus becomes enlarged because of the collection of blood. And postmenopausal women with some stimulation or estrogen intake, or even phytoestrogen intake, like estrogens from soy milk or soy products, can restart producing some endometrial stimulation and have a small or big, sometimes collection of blood inside in an otherwise uh, uh, small and closed cervix. That can be a problem. This is a thick endometrium. Endometrial thickness can be minor, moderate, or really big, really thick. If we have a patient with an enlarged uterus and a really, really thick endometrium, we have to rule out endometrial cancer. In my medical environment, the attending gynecologists like more the diagnosis of fibroids than endometrial cancer. They don't think much of endometrial problems as cause of abnormal uterine bleeding. And I have some patients, several, diagnosed and documented with abnormal endometrial lining and managed like a fibroid or expectant without a diagnosis, without a pathology, without an endometrial biopsy. Anyway, this is a thick endometrium on 11 centimeters length uterus, but this looks like an stimulated endometrium. See, this is darker than this. This usually is hormonal. This not always hormonal. Anyway, thick endometrium with normal sized uterus, 8.3 centimeters length uterus. Endometrial is 17 millimeters or 1.7 centimeters. The ovary behind the uterus. Thick endometrial, normal size uterus. Endometrium is 9 millimeters. Premenstrual endometrium looks like that. Thick endometrium, mildly enlarged uterus, 9 centimeters uterus. Thicker endometrium, enlarged uterus, 11.5 centimeters uterus. Really thick, ugly endometrium. This goes like this. Two centimeters wide, an anteroposterior axis endometrium that qualifies as really thick endometrium, abnormal. Biopsy, similar to that. One more, really thick endometrium, almost 3 centimeters width. The line and the enlargement or thickening of the endometrium. With abnormal bleeding, usually they have prolonged bleedings with clothes and all kind of stuff getting out. And this patient had abnormal bleeding after a dilation curettage procedure. And we find a small endometrial rounded mass here. In order to find a 1 centimeter mass, if you move like this, you will not see it. You have to move slow. You're better than a CAT scan and cheaper. Slow, and you can make small cuts and find things like this. The 3 millimeters endometrial polypoid formation depending on the anterior endometrial wall. This can be managed by a DNC, and if you're lucky, you can get it out, or by a hysteroscopy, which is the ideal way to manage this. You go through here with the fiber optics thing or camera and take a look and take it out. Another image of endometrial polyp. The difference between a submucous fibroid and a polyp, you can actually tell that by ultrasound unless you have this, which is not a fibroid. But with this, you cannot tell if that's a small fibroid or a polyp. Polyps show images very different in epigenicity than endometrium or myometrium. That can be a polyp, and that can be a polyp. But this is a fibroid, see? This small thing looks like this gray shade color. This looks more than to like myometria than other thing. So this should be labeled after probably submucous fibroid. Endometrial thing, usually cause of abnormal gynecological bleeding with some cramping sometimes. If you happen to have the volumetric rendering machine, you can actually see that pretty, that nice. The endometrium and a little spheric thing inside. On the conventional ultrasound imaging, on the 3D render reconstruction. Not that enlarged uterus, endometrium more or less normal, and then the ball. Anterior and by the left side of the mildly bicornuate uterus. Submucous mass, volume rendering, mass, mild notch. You can see this line. See? This is a uterine collection. Some presumably scarring tissue. You can see this after DNC or with the background of a DNC of a uterine procedure on his uterine synechia. Sometimes this can cause the amniotic band syndrome in pregnancy. So we have a submucous mass, some synechia, and a collection. In the volume rendering, we see an ill-defined thing inside. This is the uterus from outside. This can be seen sometimes as if you were performing a laparoscopy. And with old machines or basic, relatively ugly machines, you can use that, diagnose that, be confident of what you are saying. You have a submucous mass. This is the endometrial lining. This apparently is the surface of attachment to the uterus and the ball, and the vaginal approach. It looks nicer from the pelvis than from the vagina. The same mass, 2 point something thing inside, probably a submucous fibroid. And a very complex thing inside the endometrial cavity. With no color Doppler significant findings. A patient with abdominal bleeding and a really small submucous thing. See how the endometrial lining is here interrupted. The ovaries. And then, again, everybody has the right to have two pathologies, coexistence of things. An abnormal submucous thing seen on long axis of the uterus, transverse axis of the uterus, submucous mass, 8 to 9 millimeters, really small. Sometimes small things bother big, like with pain or bleeding, especially with bleeding. And that next thing, I can call it ovarian at first sight, but see this? This is like a sausage which you twist. This is the usual appearance of an inflamed tube doing this. So it probably is not the ovary, but the tube, which becomes like that after infection, surgery. Here we have a submucous mass, which we don't know if it's a polyp or fibroid. I would bet for polyps. It's very common. This is either a polyp or a submucous fibroid. See how the endometrial image is interrupted here. It's really small, 7 millimeters. Again, moves slow and you will find things that others don't find. Same patient as this. The poor lady, I say, she has something there. Then somebody put her on taking estrogens. Still a year after, abnormal bleeding and something in the endometrial lining. So we can have fibroids of all kinds. Big, medium size, 2 to 4 centimeters, and big, more than 4, small, less than 2 centimeters. Fibroids usually don't hurt. There's a professor in Canada, Dr. Ed Lyons. I seen him lecturing for an hour just saying, fibroids don't hurt. If it hurts, it's not because of the fibroid. Well, usually fibroids don't hurt. Irritable bowel hurt. If you eat too spicy, it hurts. You have an infection, it hurts. Fibroids usually don't hurt. Fibroids, what they cause is abnormal bleeding. And can be small or big. It's a really big, 7, 8 centimeters diameter fibroid. Sometimes they're subserose, they bump outside the uterine surface. What the surgeon does here in order to be conservative is they inject vasopressin analogous and prevent bleeding, and then they take out this and do the stitch. It's not nice to see thing. They say they're very good. And they're my friends. So fibroids can be small, medium size, or big, subserose, submucose, and intramural. They're all kind of fibroids. I say de chile, de dulce, y de manteca, which means spicy, sweet, or greasy, like tacos. Submucose mass, endometrial lining, submucose hypoechogenic, which means darker than the rest, and on the uterine fundus, another one with a thick endometrium. We can find that on a septated uterus. See the B shape or endometrial lining. Complex uterus. And now we pass to a uterine collection with low insertion IUD. Distance between the tip of the IUD and the uterine fundus is almost 5 centimeters. It's closer to the cervix than to the fundus. This patient had pain, fever, and abnormal bleeding after a DNC, and she had a bicornuate uterus. Remember, DNC is a blind procedure. We don't usually know what we are doing by looking at it. unless we have an ultrasound machine inside the room. So I have a portable machine, and usually whenever there's a need, I got into the NC room and check if everything's empty and if there's not a uterine accident like a rupture or something. You know, if you have something is for being used, it's not a decorative thing. To have an ultrasound allows you to do many useful things. So micronet uterus, which was partially evacuated, the endometrium is thick on one side, which means on that side there's a leftover. And that can happen after birth with retained products of conception on the endometrium. This is very heterogeneous. This is like 2 weeks after birth with an enlarged uterus, abnormal or more than usual bleeding. And she needs uterine cleanup. The so-called emergency pill, well, that causes abortions, miscarriages, quoting. And this is the intended effect. Abnormal bleeding, which is not abnormal, is highly predictable, of a not that early pregnancy, probably, which doesn't show here, but is consistent with the process of thinking that she had been taking the emergency pill. And sometimes after taking misoprostol, there are some things that are not have not came outside yet, and she had an abnormal prolonged bleeding with something in the uterine isthmus right behind the internal orifice. Sometimes the cervix gets closed and tight, and then the bleeding or whatever you have inside keeps inside. This is a transvaginal image of a small, you can notice 4.8 centimeters length uterus. What's happened here? She had an obstetric hysterectomy, which usually is not a total hysterectomy. You put 2 clamps and tie it, try not to injure ureter or uterine vessels, and keep the cervix and a small part of the uterine body or isthmus. So this patient had a subtotal obstetric hysterectomy, and this is what we find for her. Small uterus left over. And here comes the strange things that you can find sometimes. A lady who's not feeling well 3 months after delivery, with bleeding, with nausea, with positive pregnancy test still, with high levels of gonadotrophin, on bichromate uterus. Again, my father says every uterus is bichromate of some degree bichromate. He's an 85 years old GYN. So this is the left horn, empty, no strange things in. And this is the left horn. This is right, this is left. See this? This is not normal. The endometrium looks wider and something's here. What's happening? With a closer look, we found this. And what we should do when we found this on that clinical information that we have, that 3 months after delivery is still vomiting, well, we put some color on the anexa. The 2 ovaries are perfect. And we put color on the uterine arteries. This is a low resistance right uterine artery. This uterus thinks that is still pregnant. This would be perfect if seen during pregnancy. This would mean this lady will never develop high blood pressure associated with pregnancy. This is a low resistance uterine artery. The left uterine artery is even lower resistance and really highly vascularized left side on the uterus. This is not normal if her baby is 3 months old. What that means? This lady ended having a hysterectomy because trophoblastic postpartum disease. This is the image that can be a choriocarcinoma. So we should make an examination of liver, the whole abdomen, both anexa. In a closer view, see that this bunch of blood vessels on the whole uterine wall more vascularized than usual. And the image we saw indenting the endometrial cavity, this is a tumor. And that's a tumor with 2 nutritional blood vessels. One is attached to the posterior endometrial wall. This one, that's anterior, that's posterior. The other one is attached to the anterior and lateral wall. So, what to bring home? You will receive all kinds of patients. Patients who say, I have pain on the ovaries and they have colitis, irritable bowel. They eat too spicy, or they take Coca-Cola, or whatever, junk food. Or abnormal bleeding, abnormal menstruation, or a suspected mass. Those are the basic 3 reasons why somebody needs a gynecological ultrasound. The most usual cause of pelvic pain all over the world, I think, is irritable bowel. And you will see it, but you cannot label everybody as irritable bowel, even if they got into your office with a Coca-Cola in hand. You cannot do that. You have to look at the pelvis. If you know anatomy and you know what's up on the screen, down the screen on each side, then you are being clinic with the ultrasound, because ultrasound is basically clearly a prolongation of your sight. It's not like x-rays. It's you looking inside so you can know what's going on. The causes of bleeding, IUD presence, endometrial causes, or fibroid. Usually is that. Or she got the emergency pill, started bleeding, and she didn't know why. And the causes of mass is she doesn't have a mass, or she has a fibroid. It's not common to feel an enlarged ovary unless there's a uh, big cyst or big mass on the ovary. But as I told you, in order to say is your colon, not your ovaries, you must clearly see both ovaries and unrelate that to the sensitive area. If you press the colon and she says, ouch, that's usually the reason of the pain. But you should still document both ovaries, the uterus, and nothing wrong. Fibroids usually don't hurt. And not all bleeding comes from fibroids. Remember, endometrial causes of bleeding are important. Take your time. I trained this in a hospital where we used to see with 3 ultrasound machines, 100 patients a day. 3 of us, 100 patients a day, 30 patients a day. No computers, just typewriting machines. Even like that, don't rush. Don't make conclusions before being sure. And learn how to say, I don't know. But usually with ultrasound pelvic examinations, after a good ultrasound examination, we usually know better. It's not biased information. We are actually seeing inside. It's evidence. It's first-hand of evidence. Sometimes we cannot take pictures. So build confidence with your referral physicians. Do your best with whatever machine you have. Do your best. How? Training. There's a lady who came in for gallbladder ultrasound. Take a look at the uterus. Nothing will happen. I have diagnosed situs inversus on pelvic examination patients. And then the referral physician said, oh, how come you find out that she had situs inversus? The liver on the wrong side and the heart on the wrong side and everything on the wrong side. Well, I said, I saw the left ovary on the right side and the right ovary on the left side, and it came to my attention. Oh, okay, he said. And like a month after that, he was chasing me to get revenge because of the joke. You take a look at everything you can. And again, if you see that animal, email me. And I think that's all for today. How about that, Mark?
Hi, Pedro.
Always a pleasure.
We thank you for such another exciting presentation on abnormal pelvic ultrasound. And we are very glad to have you. Shall we give a hand of applause to Pedro?
Okay, I think I taped the meeting and I will let you know and send you the link, okay?
Okay.
Have a nice day and keep working.
All right. So we'll talk later in the day, Pedro.
Okay,
All right.
bye.
Bye, Pedro.